I'm going to give a quick introduction. I don't want to waste a lot of time doing this, but I did already introduce Dr. Gatan when we did our pediatric session. So you've all met him before. He did the vast majority of his training out in Washington, with the exception of his Princeton time. And his two great loves in neurosurgery are epilepsy and pediatrics. And so tonight he gets to join his partner for this epilepsy talk. And then Dr. Panov, who hasn't presented with us yet, but we're happy to have him tonight, is an assistant professor of neurosurgery in our department and director of the adult epilepsy program. He did his MD at Jefferson, residency here at Sinai, and then a functional fellowship out at UCSF, where he honed his various functional skills, including epilepsy. So the two of them together have developed a really state-of-the-art epilepsy program that is, I have discovered in my time here now, is really leading the way in forward for epilepsy surgery. So I look forward to hearing from them for the next hour. So I'm going to give up my screen share. And Ted, you can take over.
Sounds good. And just to be safe, can one of you guys nod that I am on speaker? Okay. So thank you everyone for joining. It's our pleasure to do these, and we're proud and honored to be the concluding segment for this year. I want to apologize ahead of time. You guys may hear some screaming. I'm doing this from home, so if the screaming includes words, it's probably the 4.5-year-old, and if it doesn't, it's the month-year-old. So please forgive me, and we'll try to keep them in a different room. What we wanted to do for the subject today is probably go a little bit more in depth than just a general overview lecture, but I hope you guys will enjoy it. The title is Brain Responsive Neurostimulation in Treatment of Drug-Resistant Epilepsy. So we will take a 30,000-foot view first as to how we've gotten to this point. We'll review the current standards, and we'll also see some of the pathways into the future, how we can make this field better. Now, one of them would be me being able to advance my slides. Great. All right, so these are the disclosures. So we do educational lectures for Zimmer Biomet and NeuroPace. So how did we get to something that sounds as cool as responsive neuromodulation? Where did we have to start? Well, a quick pitch here for a book that I love, The Great Bridge. So, you know, to have the Brooklyn Bridge and to have the Golden State Bridge, you had to start somewhere. And I pass the Brooklyn Bridge twice a day on my way to work and on my way back. And without really knowing the history of it, you would not be able to appreciate the incredible structure that is. Just a quick aside, it was the tallest structure in the world as it was being built. Got beat out by the Eiffel Tower during the process, but just to give you the sense of the scale and what they had to accomplish at the time. So these are some of the shots from the book by David McCullough. So if you want to, and if you have time during your trail, go ahead and bring this on the airplane. And that's the Golden Gate Bridge being built approximately 60 years later, still an astonishing feat of engineering. So let's go back all the way to the birth of neuromodulation. And here I would usually pin, but you know what, let's not put anyone on the spot, especially people who have potentially heard some of these slides before. So if we go all the way back to the beginning of neuromodulation, the first neuromodulatory device was this disgusting looking creature, and that is Torpedo nobile. That is an electric eel based around the Atlantic Ocean and the Mediterranean. And what some of our predecessors had to do, including Scribinus largus in ancient Rome and Ibn Sina or Avicenna in the Middle East, they had to actually persuade their patients to allow this creature to be held to their head if it was for treatment of headaches, or to, let's say, their lower extremity, big toe, if it was gout, until the electric eel would deliver the shock. Then they would have to have that patient go home, recover, and they would try to persuade them to come back and do it again. You can see that this was not the most appropriate way or potentially the safest way to treat the patients, but that is all we had. We had no understanding really of electricity, of how these things potentially modulated the nervous system. There's another great image as to what this thing actually is and how cumbersome it would be to use this as a neuromodulation device. The advancements after that really flattened out. And you know, we know that as the Dark Ages, although some of the medical knowledge and advancements were continued in what we now call the Middle East, due to some of the restrictions from Islam, the advancements could not really be pushed as far. You know, there was no cadaver work that was allowed to be done. and a few other limitations regarding who was allowed to be a physician and who was not. So the Dark Ages continued for about 1,500 years, and patients that we're talking about here, epileptics, dystonics, were really labeled as witches, warlocks. They were considered possessed. And just imagine the horror of that. You already have a disorder. At the time, epilepsy was considered to be contagious. So think of what it's like to be a patient 500 years ago, where you're considered not just a witch or a warlock, but also are shunned by the society, thinking that you can actually get other people infected. The Witch's Hammer, Malleus Maleficarum, was a guidebook. So think of this as Greenberg from 1486 that told young students like you how to find witches and warlocks and what to do when you found them. And of course, if somebody told you they were not a witch, that meant they were a witch. So our patients at the time were burnt at the stake. And as we say before, seizures were considered infectious. This was not just Middle Ages in Spain. This continued over into the New World, and you can see the Salem witch trials here in the bottom. We move on to the beginning of the 19th century, so early 1800s, where Giovanni Aldini started experimenting on recently beheaded and hung prisoners and freaked out half of London by being able to make a recently deceased prisoner move arms and legs and grimace. So this is considered the first successful cortical stimulation of human beings, unfortunately not alive human beings. And there are some rumors that this character right here, Mary Shelley, witnessed a few of these executions. She would have been around 5 years old at the time. So it's difficult for us to say how much of an urban legend it is. But if you think of Victorian Britain, they really did not consider kids to be kids. They were just little adults. So people do agree that most likely a 5-year-old would have been there watching an execution. So she was distraught / inspired by this and created her masterpiece here, Mary Shelley's Frankenstein, 20 years later. So now we move on to into the 20th century, and we're talking about the development of targets. Now, so we've made some advancements. We now know what electricity is. We know how it functions. And due to some serendipitous events in the early 1950s, we're able to create our first DBS target. Young, brash neurosurgeon Irving Cooper was doing a subtemporal approach and got into some bleeding, had to take an artery. Didn't really know what it was at the time, ended up being anterior choroidal. Patient woke up, had no symptoms, no complications from it, except that the tremor disappeared. So they started searching and trying to figure out what was happening in these patients, and they realized it was a small stroke in the area of the basal ganglia. Irving Cooper then continued this research, tried to actually ligate the anterior choroidal in many patients, some with poor outcome, moved on to lesioning, then moved on to lesioning of the GPI, moved on to lesioning of the thalamus, and even some early cerebellar work to try to control everything from tremor to epilepsy. And jumping another 40 years, we're finally advancing to DBS as you guys probably know it. Right? So instead of creating lesions, we have found out that you can create a reversible lesion by sending current through the target and stunning it, as it was understood at the time. We now know that that is heuristics. That is, that is not actually what happens. But as a theory, it still works, and it's a good way for us to explain it to ourselves. And it's a little bit of a shortcut until we truly figure out how DBS works. So these are two legends in the field, Benabit and DeLong, who started neuromodulation in the late 1980s, early 1990s. And you can see here, this is a simulation of an electrode with contacts activation, and you can see fibers running by. We at this point are able to modulate which way that field goes with the concept of current steering. And throughout you guys' career, I'm sure there'll be much more advances regarding segmented electrodes that will allow us to steer the currents even better than we do right now. Now let's catch up on the other end of what we're talking about, and that would be epilepsy, right? What has happened in epilepsy to get us to the point where we are? And this is compliments of Sadi Gatan. This is one of my favorite photos. One of the first stereo EEGs back from the 1950s in Hospital Saint Anne in France. And you can see clearly this very French human being is smoking as he's getting his stereo EEG implanted. So the basis of the Taylor-Rack grid, which you see right over here, really locked them into creating all of these implants in a similar fashion. They all had to be orthogonal. Each one of the electrodes had to fit through one of these holes. They would go ahead and do some of these horrific, torturous procedures that you may know of like a ventriculography. So they would inject air into somebody's ventricular system, spin them around on a chair to get that air to circulate. And then they would shoot an X-ray, which would allow them to outline the ventricular system, get the coordinates for anterior commissure and posterior commissure. And then based on that, after shooting an angiography, they would design trajectories which were safe. Needless to say, we have come a long way. And at the time, this was really only done for resective surgeries. And a little bit of lineage. So this is Gene Talarak talking to Pat Kelly. Pat Kelly then trained a lot of us over at NYU, including Brian Coppell. So we're only a few generations away from the creations of these methodologies. Now, stereo G itself really stayed in Europe and made its way to Canada, but not truly to the United States for a long time. The United States really continued the push with grids and strips, which was mostly began at the Montreal Neurologic Institute with Wilder Penfield. And it seemed like the world for a time just split into these two ways of doing it: grids and strips in the new world, and then stereo G in the old world. We're hopefully meshing those two together as best we can currently. We began then following in the footsteps of other giants, and that would be closed loop cardiac pacing. Funny story about what you see right there. The reason why pulse generators look the way they do is they were created by looking at a shoe polish box. That was something that was widely available in the 1940s and 50s, and they were trying to create the first implantable pulse generator. They said, well, what do we have on file? I said, well, look, these shoe polish boxes are easy to produce and we know how to do it. So that's the reason for the shape. We are at this point still pretty far behind where medicine is with cardiac stim, but we most certainly are making gains. And for sure, the human brain is a much more intricate device. I don't want to get you on the right side or the wrong side of that argument, but I think we'll be able to make much more advances because the human brain will actually work together with the neurostimulator and neuromodulator. And we think that that can improve outcomes. So we've gotten to the current state. So what can we do right now for patients to help them? Well, Medtronic is probably the one that you guys know of, and that's a fairly standard turn it on and let it go way of stimulating the brain. Then here you have Boston Scientific, and here you have old St. Jude's that was renamed into Abbott. All different devices, but all pretty much doing the same thing. They're able to stimulate the brain at a set pattern. There are some variabilities that are coming on board. Abbott now has a segmented lead, as we spoke about before, that is able to direct current to a point and to allow you to steer it away from structures that would be causing complications if they were stimulated. Medtronic bought something called the Sapiens device, which is a 64 segmented lead back, I believe in 2013 or 14. Unfortunately, you can see how long development takes because that has not been brought to market as of yet. And on the bottom half, you have responsive neuromodulation. And that is what we now use in epilepsy. And that is what the concentration of this talk will be on. So a quick background, as Peter so eloquently phrased, and thank you so much for that introduction, as to where we have come as a center over the past 5 years or so. And I'm sorry, the photos don't come up at the same time, so I'm just going to go ahead and bring these all up, and then we'll talk about them. So we switched under the guidance of Dr. Gatan to stereo G implantation back in January of 2016. Still remember that case like it was yesterday. We used Christmas and New Year's to prepare. And this was a young kid over at the BI hospital who did great. And we ended up localizing 2 of his, I believe, 12 tubers as being epileptogenic. And then in the following procedure, he was able to get those resected and is doing well. We ended up getting robotic equipment about 5 months later, and we're able to do our first robotic stereo G implant. So we're going on a little bit more than 4 years of that. And here you can see that first case, and you can see the first robotics case. And a little pitch for a Netflix show, if you guys are interested. Episode 2 of Diagnosis is about our center and Dr. Gatan treating a pediatric patient with responsive neuromodulation. Directional thalamic lead was implanted by us at this point more than a year ago, and that most likely is the first in the world, since the only company right now that has a steerable current device told us that no one else has done this as of yet. We've implanted at this point over 2,400 stereo G electrodes, and we're maintaining our pace as second in the world in RNS implantation. Here you can see the new 3T MRI suite, which allows us to place these electrodes if we want to under MRI guidance, as well as to complete laser ablation procedures and the resection verification if needs be. you can probably see, sorry, it's missing from my screen, but you can see the big metal doors behind that group in the back of the bore. Those open up into our new operating room. And Peter actually should have put in the video, we opened that door for the first time just this past week to lots of fanfare and applause. And now this magnet is fully function integrated with the OR. That is us inserting one of the stylets for one of these laser procedures. And that is the group that makes it all possible. So now RNS itself, responsive neuromodulation. So how is this device different and how we're able to help patients? Well, the main difference for us between the current deep brain stimulation devices and responsive neuromodulation is, of course, that it's able to detect and monitor. Right? So you have this continuous loop of monitoring brain activity, detecting a patient-specific pattern, and right now that is what we would say epileptogenic activity, and stimulate it to try to abort the seizure from occurring. Now that is just, the tip of the iceberg. The detection patterns can be varied. We're hoping that in the future we will be able to detect everything from an onset of a Tourette's episode to an onset of an obsession where you would not need a compulsion to be able to deal with it, tremor and essential tremor, decrease in the effectiveness of a Parkinsonian medication. So a lot of things that can fall into this box. And Marty Morell, one of the creators of this device, is always laughing that this record function, which we now find so amazing, and it has just been a treasure trove of potential research, was just thrown on later on by the engineers. They said, well, it's probably a good idea. Why don't we also record some and have it be able to be downloaded later? So this is really the first device, the first brain implanted device that can give us years of data about a patient who is living and working in their own environment. No longer is the artificial nature of an EMU necessary for us to be able to catch seizures. This can happen when they're out there living their life. Personalized detection for each patient is a key, right? So the device has to learn after it's implanted. We usually give it about a month for it to learn the brain waves from the area where we're picking up detection. And then in close collaboration as a team, it's decided to say, well, okay, well, these waves right here most likely are signifying an onset of a seizure. So let's go ahead and try to treat those. And slowly then the device will learn to recognize those. We can add on multiple from that, multiple different iterations and multiple different simulation tactics. And that allows us to try to control the seizures better and better as we go. So this right here is the way for us to be able to explain it to a patient, and I use it to explain it to myself as well. So it begins with the neurostimulator and the lead itself at 12 o'clock. The providers are able to interact with that using an RNS tablet, and you guys have been probably in clinic. You may have already seen this. It's similar to the DBS programmer devices. The patient management data system allows the patients to go ahead and upload into the cloud, which means that at any moment, as needs be, an epileptologist can take a look at what's going on in the patient's brain and figure out if the patient's in trouble. And in my opinion, patients love this portion right here, this remote monitor. They feel like they have a lot of control about what's going on. They feel like they're able to help in their own battle against this disease. So this is a little bit of a busy slide. And I'm sorry the animation didn't work, but let's just work our way through it. How do we actually use responsive neurostimulation? How do we decide which patients are able to undergo this procedure? So the first step is going to be, you need to identify how many seizure onsets areas you have. Right? So if something is not localizable at this point, the FDA says proceed with other neuromodulation options. Let's say you have generalized epilepsy. Off-label, we are pursuing these ideas with NeuroPace, but right now on-label, this would not be the way to go off to the right. Let's say we're confident that there's one area and that's the seizure focus. Then you go through this pattern of, is it something that is safe to resect? If the answer is yes, talk to the patient about the possible cognitive risks of that resection. If the cognitive risks are low, talk to them about the possibility of being seizure-free after this procedure. And if that seizure freedom is likely, then you can proceed to a resective surgery or to an ablative surgery. If any of these questions are answered no, then most likely responsive neurostimulation is the way you'd want to go. And if there's more than one seizure focus, then again, most likely neuroresponsive neurostimulation is the appropriate treatment for the patient. And I really do love this plus sign right over here, and we'll stress that a little bit later in our talk. The implantation of responsive neurostimulation, especially now with the MRI approval of the device, which means we can scan the patient's heads if they have this implanted, in no way does it preclude an eventual ablation or an eventual resective surgery. You may actually be much more sure, and you may be able to give much better answers to the questions of seizure freedom and cognitive risks if you have data from years via responsive neurostimulation. So let's go through a little bit of the clinical evidence as to why we're so confident that this is a good option for patients. Well, the trial itself has been going on for a while, and a 9-year follow-up came out this year. Represents almost 2,000 patient implant years. And you can see here the feasibility trial had 65 and the pivotal trial had almost 200. After the pivotal trial concluded, the open label study has been going on since then. And there's another post-approval study as well that's occurring right now at 30 different centers. And it is pretty incredible. We'll review that data later in the program as to how much better we have gotten at getting these patients the response that they need sooner. So the prospective trial population, and in your mind, you sort of want to say, okay, well, we know that this works for the patients in the trial. So if you're going to go ahead and get this into your practice and you're going to talk to your attendings about this, most likely the patients you'd want to start with are the patients who were in the trial. So you can see the demographics here, fairly young population as we usually see in epilepsy. This right here is that scary number we always talk about, right? So they have had epilepsy for up to 20 years. And we need everyone's on this talk help to get that number down, right? There's no reason for patients to suffer for 2 decades if we know there are good treatments for them. And the median disabling seizures per month, 10. Just imagine what that does to a human being, right? 10 times a month, you're going to be beyond inappropriate in a social setting, and you don't know when those times are going to be. One of the most horrible things that can happen to a person is a seizure in public, not to mention even just the possibilities of hurting yourself, but what that does and the lack of the ability to control your life. So history-wise, splits evenly. 1/3 were previously treated with VNS, 1/3 were previously treated with epilepsy surgery, and about 1/3 did not have any intracranial monitoring. So these are not the easiest patients. I would even argue that these are probably the toughest patients that we used in the trial. A lot of things have already been tried to help them and were not successful. This takes you through the seizure onset regions, neocortical versus mesial temporal, or both. And lower right-hand corner outlines the mesial temporal patients themselves, the majority of whom were bilateral. And that initially was one of the main indications for neuropace. This would be bilateral mesial temporal lobe epilepsy. And then you have the neocortical patients here with a split up into the lobes themselves. So here are the prospective outcomes at year 9. The tremendous thing about this device is, again, unlike resection surgery, where with every year a few patients recur, so the success rates drop. Unlike ablative surgeries, where same thing, every year a few of the patients will recur. It seems that this device continues to get better and better the more years it spends communicating with the patient's brain. So we think that there is some sort of entrainment that is happening, be it plasticity, be it just synergy between the device and the human brain, but we are getting better year after year. So you guys can see the median % reduction in seizure frequency is right here. And you have the number of patients right here. And you can see that going year by year by year, you're continually getting more and more patients with a significant seizure reduction. And these numbers here are pretty striking, right? Almost 1/3 of the patients had at least one period of more than 6 months without seizures. You've had 35% of the patients achieve greater than 90% seizure reduction in their follow-up. So again, we can do better than just a patient continuing to try another medication and continuing to seize. So this is a seizure reduction and where it occurs. So you guys can see, of course, sort of the workhorse and what we know from studies. Mesial temporal lobe epilepsy is the bane of the existence of the majority of medically refractory patients, but it is incredibly susceptible to surgical interventions. And we can see that repeating here because the mean change is -70. Frontal lobe, also very successful. lateral, temporal, parietal, occipital. You can see that in all of these areas, responsive neuromodulation may make a difference. We're now making some great strides regarding thalamic stimulation as well, to try to really hone in on the network in its entirety and to see how we can get even better at the treatments. And this just gives you an illustration. Again, mesial temporal patients versus neocortical, which is really everybody else. And this should be sized slightly different. So, this bar should not appear as high as this one. But you can see that the mesial temporal patients potentially will do great with this procedure. 3 months of seizure freedom is nothing to sneeze at if somebody has been seizing for 20 years. And this right here, the 15% and the 14% in the lower right-hand corner are what we call super responders. And right now, a lot of very, very smart people are trying to work on how do we get everyone else to be in that group. What is it that we are doing, or what is it that's happening with the super responders that is not happening with the other patients? If we can get everyone into this group, I do not mean to sound sacrosanct, but we may never do resective surgery or ablative surgery again. Neuropsychological benefits. Again, this is a huge portion of what we deal with. These patients are young. They want to be contributing to society. They want to be able to move on with their life. They want to be able to go back to their work. How do we prevent the decompensation neuropsychologically if they continue to seize or if they have a resection? Well, we're seeing here that because this is a reversible lesion and because this does not occur all the time, it only really stimulates when needed, we see that there are actually statistical improvements in neuropsychological outcomes, and declines have not been experienced. You can see naming, verbal learning, visual memory, and executive function. This is also a good kind of sweeping outline. So the only things that really did not make it into positive change here would be pain and physical function, but everything else, and you can see the dots here, would be statistically significant regarding their quality of life, improves. And the cutoff seems to be somewhere around 10 to 15 years. If they've had seizures for a really long time, it is difficult for the patients to recover on the neuropsychological perspective. And we can have a whole other lecture about the potential secondary gain and how their life now is so centered around their epilepsy that it is actually a significant stressor if their epilepsy is now better. And this one is key. The rates of sudden unexplained death in epilepsy and the fact that those rates drop significantly once the responsive neuromodulation device is in. This is the one slide I want you to take away from this talk. Right? So this is per 1,000 patients. You can see that epilepsy surgery candidates have a significant risk of SUDEP. And you can see how that's dropped about 5-fold in patients who do get the RNS system. Safety, right? So of course, this is a surgery. This has risks, and we all know that. But as we, as a community, are getting better and better at managing these risks and reducing those risks, these numbers should fall even further. So no adverse cognitive effects, we've already covered that, right? No chronic stimulation side effects because it is responsive. It does not stay on at all times. The rare serious adverse complications are comparable to other deep brain stimulation procedures that we perform. So bleeding and infection are the two main ones. So the rate of hemorrhage in the implant procedure is what we're now used to seeing in neurostimulation, somewhere around 1 to 3%, usually with no long-term sequelae. Infection risk remains a significant morbidity. And no matter what really we have done in Neurosurgeons Society, if you're implanting a device, you should quote anywhere from 2 to 4% of an infection risk during the lifetime of the device itself. And you guys can see here that even though the infection risk is close to 4%, the explant rate is less than that. So about half of these patients are able to be treated through with antibiotics and are able to salvage their devices. So let's talk about how this is a window to the brain for the patients, right? So remember, this is something where the engineers came in and said, why don't we just throw this in? And it is amazing what that has created. So long-term RNS data may help you really be able to tell what's happening with the patient. Imagine this situation. The patient has always been seizing. They cannot drive. They get the responsive neurostimulation device in. They come in for their next visit and they say, doctor, I've been seizure 3 for the past 3 months. I really want to drive. Number one, what do? Well, you look at their RNS device, and the RNS device clearly shows that they're seizing, and those seizures are being aborted daily. What do you tell the patient? Well, right now, all of our scales are a subjective evaluation of the patient's perception of their own seizures, as well as their family. So yes, that patient is seizure-free by our scales. Yes, the device is working correctly. And when they make it to the next appointment, most likely you will be able to let them drive. But it's changing everything in our field. It's changing the way that we probably will have to grade these patients. It's going to change some of the scales that we use now that we can see inside of the brain in a chronic pathway. It will be able to reveal patterns to patients' epilepsy. And I want to refer to you to the work by Vikram Rao at UCSF. He's really pushing the agenda here and really getting some incredible data, telling us that while seizure patterns are not related between patients inside of a specific patient, the patterns of seizures are incredibly consistent. Patients will have more seizures at certain times of the day. Patients will have more seizures at certain periods in the month. And that can be every 15 days, every 7 days, every 21 days. It's not consistent between patients, but it is very consistent inside of one brain. RNS can also help us assess effects of medications that we start as a team. And it can allow us to continue to monitor and reevaluate the patient for potential seizure curing procedure. So let's take a look at the drop-off and the trends that we can see with responsive neuromodulation. So here you guys see, approximately 9 months worth of data and what we call long episodes. Remember, no one has ever really seen an RNS device implanted and what the data from it would be when they first started doing it. So no one could say, aha, this is a seizure. So what we do is instead we call little episodes that happen inside of the RNS recording as long episodes. That is sort of the way that we say we think this was a small seizure. And in a specific patient, as they continue to improve, you can see the number of these long episodes continuing to drop. And you see the trend line in red as they go through getting better and better programming with the device. Circadian patterns in seizures. You can most certainly see, again, the normalized average of detected episodes per hour in the last 12 weeks. You can see that this patient has nocturnal epilepsy. You can see the amount of long episodes that are coming up and that are not there during the days. Think about what that does for you as a physician, right? You can go ahead and ease up on some of the medications during the day so the patient can function better. You can go ahead and increase some of the dosages at night to prevent these seizures from happening. And this one right here is just so striking, right? So this is our epilepsy colleagues beginning a new medication trial. Medications trials used to take months to years. You would start a dose, you'd make sure that there's no complications from the dose or side effects. You would slowly take it up and increase the doses. And let's say the patient seizes once every 2 months. You would not celebrate after 2 months. You probably would wait 4 months and try to increase the dose. Now, having a responsive neuromodulation device and look at what happens within the month as this medication is added. The total number of long episodes drops drastically. So most likely that is the correct medication for this patient. Vice versa, if you start a medication and you see the total number of episodes skyrocket, you don't need 3 months, 6 months to prove to yourself and to the patient that that is the wrong medication. You can go ahead and move on to the next antiepileptic. This is another fascinating concept. So let's go back to the idea that we can continue to use responsive neuromodulation to, in the long run, diagnose the patients and treat it almost as a take-it-home EMU. So David King-Stevens wrote this up in 2015. In 20% of the patients, the presumed lateralization determined by prior testing changed after the patients received their responsive neuromodulation. So you can see here that 11 patients were presumed unilateral, but because there were spikes on the other side and concerning factors, they were implanted bilaterally. And more than half of them had bilateral seizures in chronic monitoring. On the other side, a lot of patients were presumed bilateral and had bilateral implantation. And you can see that a not an insignificant portion ended up having only unilateral seizures once they're out in the world living their life. So what does that allow us to do? Well, in this case right here, it allows us to potentially ablate or resect the side that is seizing and to leave the RNS on the opposite side to improve their outcomes further. This right here shows you how long you would have to stay in the epilepsy monitoring unit before the contralateral seizure is caught. And this number of 46 days, I'm hoping Sadi doesn't call BS on me, but I think we've only had one patient who made it to 41 days. We only had one person who was there for 5 weeks. Maybe she didn't even make it there. So usually after 2 to 3 weeks, we think that these patients have had enough seizures and we explant their leads. It does take a long time for somebody who seizes infrequently from the contralateral lobe to be able to pick that up. But we now have a device that is able to do that. And this right here are the outcomes of several centers where the bilateral implantation allowed for that chronic diagnosis of only one lobe really seizing for the most part, and what they were able to do with that. So you guys can see after bilateral implantation of 21 patients, 21 patients had resections of this. And out of the 21 patients that had resections, 19 maintained their system. 15 of them, that's 70%, were free of clinically reported disabling seizures. So again, for all intents and purposes, seizure-free. And for the rest of the not seizure-free patients, you can see here that the average percent from the resected side in the lower right-hand corner, the number of seizures from the side that was removed was just not as great as in the patients that were more successful. So we can help these patients, right? The majority of the patients who have this implant, after a year or so of monitoring, you potentially will be able to help them more. Treatment gaps and ways that you as the new young generation can help us, right? So why are we not treating the patients who are out there? About 1% of the population have epilepsy, and about a third of them have medically refractory epilepsy. So we're talking about significant numbers, but up to 80% are not referred to an epilepsy center. And then, as Sadi stresses all the time, only 1 to 2% of the patients who really should get the surgery get it. And that drops us down to a number we really need to work on altogether. And we need to be able to get this up. Now, how do we do this? How do we fight the stigma of the last 60, 70 years of large resections, disfiguring in the public opinion surgeries, monitoring that is torturous and difficult to deal with? Well, we potentially do that via neuromodulation. And this is, I know RNS is kind of trying out this slide, so it's probably not the final version of it, but just think about it as high cognitive risk down at the bottom here and the chance of seizure freedom being higher on this side. And additional medication does not really give you that good of a chance for seizure freedom in this direction. But an additional medication still has cognitive risk. Whereas if you move towards the center here to neuromodulation, RNS, VNS, DBS, the chance of seizure freedom improves, yet the cognitive risk is not as high as it used to be before. And then all the way in the lower right-hand corner, you can see the epilepsy surgeries, and I would say sort of therapeutic, definitive surgeries, irreversible surgeries like ablations and resections, do give you a much higher chance of seizure freedom at this time, but at the same time come again with a potential significant cognitive risk. So as you're thinking and learning about these fields, think of this as a continuum, right? You're going from medication to neuromodulation to potential surgery. And it sounds like one of the two has woken up, so I'm sorry if there's some background noise. This is a good table to compare neuromodulation therapies as we have them currently: RNS, VNS, and DBS. So if it's okay, I'll just take a couple of minutes to go through this together with you guys. So the neuromodulation target for the RNS is as close as we can get to the origin of the seizure. We look for it, we try to find it, and we try to implant that area. For VNS, it's the vagus nerve, and for DBS right now, what's FDA approved is the anterior nucleus of the thalamus. Stimulation type, you have open loop for DBS and VNS with a slight modification that's recent for VNS that allows us to target increases in heart rate. And over in the RNS corner, you have responsive neuromodulation, which actually listens for the abnormal activity before it treats. The data collected by the device right now for DBS, it's none, although the Precepts device just came out to the market. That device allows us only to sense, it does not respond. And for sensing, you do need to be in the office together with a physician, and only at that time will you really be able to download that data. VNS is able to record a certain, albeit low, amount of data. And of course, RNS at this point is able to record limitless amount of data over time. We're developing and we're trying to work with the company and this company to increase the number of leads that they would allow us to be able to place, to increase the time for which you can record. Obviously, all those things would make the device potentially larger and more burdensome, so it's always a fine balance. Stimulation side effects in this row. Voice changes and hoarseness for vagal nerve stimulation. You have depression because of the continuous stimulation of the anterior nucleus of the thalamus and some questionable memory impairments. Whereas the key to responsive neuromodulation right now, it is not a water hammer effect that just continues in one spot. Hence, we think that the side effects are very well tolerated. And you saw this in the previous slide, seizure-free periods of greater than 6 months, up to 30% with RNS, lower numbers with both VNS and DBS. Mean seizure reductions are similar between DBS and RNS. So whenever you're speaking to patients, whenever you're getting into this field, just make sure that you're presenting an objective view of everything that we can currently do. All of these things are neuromodulation. And we're hoping that all of these companies will continue to work at getting better and allowing us to deliver better care to the patients. This is a good slide to compare responsive neuromodulation and VNS head-to-head in the two trials. And you can see that initially, this is from the pivotal trial itself, right? The response rate was similar to kind of the best response rate you can get with VNS. But it is blowing it out of the water as you continue to go through the years. And this is also not us using the real world data that we're currently trialing, and numbers there look even stronger. So this is a slide about VNS itself being most likely more effective in generalized seizures. And intuitively, it makes sense, right? If the seizures are the brain on fire syndrome, where it's difficult to pinpoint and locate a specific area from which they begin, most likely decreasing the brain's overall susceptibility to seizures is the right way to go. And that's what VNS can do. It just decreases increases the protection of the brain against seizures is a simple way to look at it. And we can see right here, generalized response is better than it is with mixed and partial epilepsy. Now, these are the DBS and RNS clinical trials. And you guys can see here the seizure-free intervals, as we discussed before, 28% with RNS and 18% with DBS. Greater than 12 months was not reported in the workup for the anterior nucleus of the thalamus in the Sante trial, and is reported up to almost 20% with the RNS system. And what I want to do is a quick pitch for a publication that is coming out tomorrow, as far as we know. And this is the hard work of Dr. Gatan and the future hard work of Peter Morgenstern. Off-label usage of responsive neuromodulation for the past, at this point, 5 years has allowed our center to be the highest implanting center for kids to be able to help them with epilepsy. Over 30 patients have been implanted. I believe the youngest is still 7 years old, has grown since then, but that was the age of the implantation. And more than 50% of the patients in this group have 75 or greater seizure reduction at 1 year follow-up. So most certainly we know that we can help patients, and I want to leave you guys with this quote right here. It really struck me when we were finishing the paper. Both children and adults belong to the human race, and progress in medicine can be applied to and be of benefit to all. The transition from childhood to adulthood should not be one of continuity, should be one of continuity rather than of migration. So do not think of a 17-year-old as different from a 17 and a half or an 18-year-old, right? If something helps a human being, there's a great chance that it will help another human being. So at this point, again, I want to give a shout out to Peter because we finally got him down here. We just have to get him into one of the photo sessions where we're all together. It is a big team that makes this possible, and we look forward to each and every one of you potentially coming over and visiting us and developing these relationships in the future. So I want to thank you and leave some time for questions.
I see one question in the box. why is the use in children not yet approved by the FDA? You guys want to take that one?
Sadi, you want me to start with just one sentence of saying it's bureaucracy, right? It takes a very long time for anything to be approved by the FDA. The responsive neuromodulation device was thought of back in the late 1990s. The initial work began in 2003, and it took so long for us to get to this point of FDA approval, and that took 10 years. Right? Yeah. So as of right now, there's different pathways, as Sadi is saying, that we can get to approval for kids. We can do safety studies like we're currently doing. The FDA may make us do another trial with pediatrics, but we're hoping that enough data would be presented in off-label usage that they would see that it is a safe and valid device to use in kids.
Yeah, I would just add that if you think about an adult skull compared to a pediatric skull and the safety of using this device, again, for something neuromodulatory, it's much more appealing to a parent, for those of us who are parents, to have their child's brain modulated rather than removed. So from a marketing standpoint, it's a much better way to treat epilepsy. From a safety standpoint, it's a much better way to treat epilepsy. And there's nothing about a child's skull or brain that is any more or less safe to place this device, as long as we make it flush with the skull and it doesn't erode through the scalp. It's sort of ironic that you can put a little bit of mass effect on the brain from the implant, but you cannot do the same thing to the skin without having trouble. So we haven't had problems placing this in children or adults. They both tolerate it very nicely, and we look forward to that FDA approval coming, because in my view, if we capture the neuroplasticity of a young person with this kind of modulatory device, we have a real chance to make a big difference earlier rather than waiting until they're old dogs like me, where you can't teach them a new trick.
That's a good one. So I see another one here. Can patients with 3-month seizure-free period be managed with anti-epileptic medication? Most likely they already are, right? So the seizure freedom in different scales is assumed to be seizure freedom on medication. So for sure, if somebody starts seizing, the first step would be to get them on medication if they've been able to be tapered off of all medication. And then the growing skull I can leave for Sadi, but he has taught me that once you get beyond 4 or 5 years old, the growing skull really presents no issues.
The size of the device is actually quite compact. It's no more than 6 centimeters in one direction. And so the impact that you're going to have on skull development beyond age 3 or 4 is very minimal. And again, as long as it's a full thickness craniectomy, there's no problem with device being spat out or being pushed out by a growing skull or deforming the skull in any way.
All right, guys. Well, I want to make sure that if you do have questions in the future, I'm going to type my email down here. Please feel free to reach out.
I'll add that I've given your email out to this group a number of times because we've had plenty of interest in the pre-residency fellowship.
Yikes.
So.
Well, I tried to give him my fake email, but I guess you already gave me a real email. No, guys, please reach out. And I want to know, Peter, do we do fireworks or something?
Before you go, guys, I have a question for you.
Go ahead.
Can you hear me?
Yeah. Yes.
Perfect. So my question is, do you have any threshold for clinical seizures or seizure patterns detected in a monitor to consider the procedure as successful?
Yeah, so, and I would refer you to the Engel scale, right? So free of disabling seizures is really our goal, but that is so subjective and still patient dependent, depending on what they do, right? So if somebody's a teacher and they have absence seizures. They may not be, disabling to any human being, but if your classroom is interrupted and if your students are noticing, to you, that is a disabling seizure. So it's an incredibly personal question, and that's why the Engel scale kind of stays away a little bit from the objectivity of some of the other scales, like the International League Against Epilepsy, that actually counts the seizures. Tough question, fascinating question. I think that over the next couple of decades, we're going to get to the point where the data from the device may potentially drive your clinical outcome score.
Thank you.
All right, well, thank you everyone for your attention tonight. Thank you to Drs. Katan and Panoff for running this session. It's really a great talk. And yeah, so this is our last session. Please look out in your inboxes in the next week or so for the post-course survey that we're gonna send out. We're really looking for your comments to improve this in the future. And we'd also like to collect a little bit of data on how this has impacted your education in this very interesting time that we live in. So thank you all and have a great night and rest of the summer, and good luck over the coming years of your training.
Thank you.
Thank you, guys.
Thanks, guys.
Bye.